All right, we are recording. Hey ho, let's go. This is Resistance Radio, where natural selection selects resistance and public policy selects who gets to survive it. Welcome back. Today, we're not just talking about viruses, we are talking about the systems and the political choices, the financial priorities, and the deliberate obfuscation that turns manageable outbreaks into body counts. Because if you work in public health and you're not naming that, you're just doing really well branding triage. So let's get into it. Our first segment will be Ebola. This is the outbreak that was always going to happen. So as we know, there's an active Ebola outbreak in the Democratic Republic of the Congo and Uganda caused by the Bundibugyo strain, a strain for which there's no licensed vaccine, no approved treatment. As of this week, we have 381 confirmed cases, 62 confirmed deaths in the DRC, plus 16 cases and one death in Uganda. The overall case fatality rate is sitting at about 16%, but there's still more than 250 suspected deaths, not yet confirmed, and still in outbreak math. Suspected usually means real, but underfunded. So here's the number I want you to sit with. The case count at 21 days into this outbreak is already higher than the 2014-2016 West Africa outbreak was at the same point. This is the largest Ebola outbreak in history. We are currently ahead of that pace. Think of it this way. If the outbreak were a race, 2014 West Africa set the record. This one is lapping it out of the gate. A CDC modeling study published this week in the MMWR lays out the worst case scenario clearly. If 20% of infected people are detected and isolated within 2 days, this outbreak could top 20,000 cases and 4,000 deaths by mid-August. And here is the structural reason that's on the table. And that is a real scenario rather than a fringe one. The outbreak has now spread into territory controlled by the Islamic State militants. Health workers do not go there. Contact tracing does not happen there. This week, a burial team was attacked in the South Kivu province. Residents exposed the coffin and the body of an Ebola patient, which is one of the highest risk transmission events possible. So let's name what this is. When armed conflict, poverty, and state collapse converge, you get an environment where a virus can do exactly what it wants. This is not a natural disaster. This is the downstream consequence of decades of resource extraction, proxy wars, and international indifference to governance in Central Africa. The virus didn't create the conflict. We did. Or rather, the people who profit from that region's instability did. They are not the ones dying of Ebola. WHO Director Tedros has now launched a joint response plan with Africa CDC, asking for $518 million over 6 months, a one plan, one budget, one team framework. That's actually the right call. It's coordinated, it's regional, and it's what global health architecture is supposed to look like. But that number, $518, is roughly what the United States spends every 16 hours on its military budget. We are being asked to fund about 2/3 of a day's defense spending to prevent a West Africa scale catastrophe. And the current administration, which has already gutted USAID and withdrawn from the WHO, has given no indication it sees that as a priority. This is not a resource problem. This is a values problem, and the values are set by policy. All right, let's move over to measles, the slow motion scandal. Nobody is prosecuting. So meanwhile, right here at home, we've quietly crossed 2,000 measles cases in the US in just 5 months. To put that in context, last year we didn't hit 2,000 until Christmas. This was the first time since 1992. We've now shattered that milestone before the 4th of July. We have now more measles outbreaks in the first 5 months of 2026, 30, than we did all of last year. That means 30 separate outbreaks. 21% of those cases are children under 5, 72% are in kids and young adults under 19. 3 babies younger than 1 got measles from a single unvaccinated toddler at a daycare center in Lubbock, Texas. Babies who were too young to be vaccinated, made vulnerable by the choices of the adults around them. Adults who were not making those choices in a vacuum, they were making them inside an information ecosystem that has been deliberately polluted. And that's the corruption angle that doesn't get talked about enough. CIDRAP this week published a piece on how physicians are rethinking vaccine conversations in the age of doubt. Clinicians are reporting that patients now arrive at the pediatrician's office armed with claims from social media influencers, wellness podcasters, and I can't believe I have to say this, and AI chatbots. Some families whose older kids were fully vaccinated are now slowing down or stopping vaccines for their newborn. That's not random ignorance. This is the product of a multi-million-dollar anti-science industry that profits off of fear, supplements, and distrust. And it's been amplified deliberately, knowingly, by political figures who found that vaccine hesitancy is a useful wedge. The WHO flagged vaccine hesitancy as a top 10 global health threat back in 2019, before COVID made it a billion-dollar brand. As clinicians, we are now being asked to out-persuade that machine in a 15-minute office visit. And we should try, but let's not pretend that the burden of this failure belongs to individual pediatricians having better conversations. Let's not pretend that the burden of this failure belongs to individual pediatricians. The burden belongs to the politicians and media figures who have decided that public health was a culture war target and that children's lives were acceptable collateral. All right, let's move into our next segment. The long tail, when recovered, is a lie. And let's focus on another story that doesn't get enough airtime. And there's a new study in the Journal of Travel Medicine and looked at what happens after people survive tropical vector-borne infections like chikungunya, dengue, Zika, and malaria. Here's what recovered actually looks like. 86% of chikungunya patients had lingering arthritis, joint stiffness, muscle pain at 1 month after their infection. 71% of dengue patients had persistent fatigue and bone aches a month out. 84% of Zika patients were still symptomatic at 1 month, and 2 patients had symptoms for a full 18 months after the study. Malaria was better, but 48% still had fatigue, headaches, and pain at 1 month mark. This matters beyond the individual patient. These are diseases that disproportionately affect people in lower income countries and communities, people who cannot take a month off of work because they have post-chikungunya arthritis, people who don't have disability leave or paid sick days, people whose governments are not funding rehabilitation or long-term care for what is essentially a long COVID equivalent for tropical infections. This is an equity story. This is a policy story. This is what greed looks like when it's structural. When pharmaceutical and insurance markets find no profit motive to study or treat the long-term sequelae of diseases that primarily affect poor people in hot countries. So in closing, let's connect all these stories. Ebola is spreading through a war zone that exists partly because of extractive global economics. Measles is burning through American children because anti-science has been commercially and politically weaponized. And tropical infections are leaving people with months of disability that nobody is paying to address. None of this is fate. None of this is, that's just how the viruses work. Every one of these outcomes has a policy fingerprint on it. And part of our job as public health practitioners, as clinicians, as people who actually understand what's happening, is to say that out loud. Not just in journals, not just in grand rounds, out here where people can hear it, because obfuscation is a public health intervention too, just one that works for the virus. This has been Resistance Radio, where we follow the data, name the power, and keep our situational awareness more contagious than the pathogen. So stay curious, stay kind, and remember the outbreak was not inevitable. It was actually budgeted. This has been Resistance Radio. My name is Mark Allen Derry. Thank you for tuning in.